Okay, so here we go. Welcome for everybody who came today. Today will be our second trial class for the USMLE Step 1 exam. So the idea overall from this exam is to explain all of the material needed for you guys to pass your steps. First of all, I would like to explain for you what is this exam. The USMLE examination system is divided into three parts. We have a step 1, 2, 3. So the step 1 is basic science that we will be explaining today. So this include all of this like general subjects like pathology, microbiology, all of this general stuff, biochemistry, the words for all of the students. And for the step 2, it's subdivided into two parts, which is the CK, clinical knowledge. It's kind of like step 1 modified type of thing. And also the CS. The CS was recently cancelled, and on its place, they replaced it with another exam called the OET exam, which is the Occupational English Test. The CS means clinical skills. And the third exam, you don't have to worry about it anytime soon. This is mostly done by resident and people who are already working in the US. So, for these two exams, the step 1 and the step 2 CK, for the student who passed these two exams, they are allowed to work in more than 6 countries worldwide. So, even if you are not planning to go to the US, there is other opportunities. Like for example, you can work in New Zealand, you can work in Qatar, you can work in the United Arab Emirates, Iceland, Ireland. So you have other choices and other possibilities to get. And today we are going to explain about how to deal with the step 1. By the way, a little bit about my credentials. My name is Iyad Youssef Idris. I already passed step 1, step 2 CK, and the OET examination, which is the replacement for the CS. I have done pathway number 6 for the ECFMG certificate. So I'm considered as a licensed physician in the US. Now we are going to speak about the step 1. So step 1, well, it's about basic science. In our course, we will be doing the following. So for today class is subdivided into 3 sessions. So the first thing we are going to do, we are going to describe how our course schedule goes, what we are going to explain in it, every little thing. So that goes something like this. From A to Z, everything that we are going to do in our course. The second thing I will be explaining for you in the first hour, something from the basic science. I will be explaining for you some pathology. Why I will be doing that? Just to give you the taste of the course and how it goes. And in the second hour, I will be explaining for you something from the clinical sciences. For example, I will be speaking with you today about cardiology, one of the difficult topics for most of the students, and we'll try to make it a little bit easier. And yeah, that will be our today's session. It will be 2 hour session. I hope that all of you guys are ready. So starting with the first section of our today's session, it will be about a full explanation of how this classes goes. So first of all, the first subject for me to explain for you guys will be the CVS, which is the cardiovascular system, and together with pathology. It's a little bit atypical type of explanation because most people will be like, why would you go with pathology and cardiology together? Well, for 2 reasons. Reason number 1, we don't have a lot of time. So we need to finish this whole course within 3 to 4 months. If realistically we want to explain every single thing in the USMLE, it will take years. So my main function is to facilitate your way of learning. So I will be telling you what exactly you should do, what you should not do, and all of this stuff. So moving back to the CVS and the pathology, this will be explaining them as the first subject together with a little bit of immunology. After that, I will be speaking about endocrinology with immune responses, GI with immunosuppressive drug, hematology, oncology with molecular biology, and you can see the dates here, MSK with genetics, and next will be CNS and biochem. You see that I gave a lot of time for that since it's really the two most difficult and hard topics for the student are biochem and CNS. Most students find it really difficult, and we will try to make you guys like master the subject of biochemistry and the subject of CNS. The next one will be Psychiatry and Ethics. It's quite a small subject, and Renal and Biostat. Biostat turns to be the most horrible subject for the student, and Renal one of the most easiest subject for the student. Two long subject will be Reproductive and Micro, and we'll finish up with the Respiratory and Pharmacology. And by the end of February, you will be ready to go and do your exam. So today we start first of all about like general pathology. I will be explaining exactly what I was explaining yesterday for the student who attended yesterday class, because this is just a trial class, and it will be something like this. So today our topic will be about cellular injury. I want you to imagine, guys, you are exercising at the gym. And when you exercise at the gym, you are doing this repetitive stress in your muscle. Let's imagine your biceps. And that leads to the biceps getting injury, actually. That injury is not bad. It's just like bad stress, but the cells are not dying yet. And that leads to what? Hypertrophy. Your muscles become bigger. That's why we exercise. So today we are going to describe the difference between cellular adaptation and cell injury. So when the cells undergo a stress, it undergoes a reversible change that will allow her to get back to normal if she needs to, if you remove the stress. So first of all, let's imagine the following. We'll speak about something totally in general. We'll speak about the lady menstrual cycle. So I'm drawing a uterus here with the fallopian tube, all of this stuff. And yeah, I know my schematics are not that good. And okay, so this is this endometrial lining. And we know that the endometrial lining enlarges when there is estrogen exposure. So when the estrogen exposure, that leads to the endometrial lining to become enlarged by two processes, hyperplasia and hypertrophy. So a lot of students will be like, okay, so what is the difference between hyperplasia and hypertrophy? That's what the USMLE examination wants you to know. So we'll speak about them a little bit deeply. So as we said, due to this stress, in the case of menstrual cycle, it's the estrogen, it's the hormone, a physiological change has happened, which was what? Endometrial enlargement. Also, it can occur in a pregnancy. The uterus becomes bigger during pregnancy. This is not pathological. This is normally physiological. This is normal. And it does so by undergoing the process of hyperplasia and hypertrophy of the uterus itself. And we'll speak about what each one mean. Sometimes it can be pathological, this cellular adaptation. For example, someone who has hypertension. So let's imagine this really quick. If someone has hypertension, so I hope you understand my drawing. This is the left atrium, this is the left ventricle, this is the mitral valve, and here we go to the aorta. So left ventricle and aorta. And here we have the valve, like the aortic valve. And there is some concept called the afterload. So the afterload is basically the amount of resistance that the blood going out from the heart faces. And the afterload is mediated by so many things, but for the sakeness of simplicity for today, we say that it's mediated by blood pressure. So if someone has chronically elevated blood pressure, the afterload will be high, which is the power that pushing back against the heart. So your left ventricle will enlarge. And when your left ventricle enlarges, one becomes bigger to maintain that amount of resistance he's facing. So it becomes bigger in size. And that we call left ventricular hypertrophy. You can imagine if the wall of the heart will become so thick, it will be much more basically having less elasticity, which will lead basically to it having something called an S4. An S4, it's when the ventricle try to push against a really high afterload, and itself it becomes kind of stiffened, and this stiffness of the left ventricle leads to the creation of S4. Okay, so from our concept here, we know that the left ventricular hypertrophy occurred. So you're like, wait a second, why hypertrophy, not hyperplasia? So first of all, let's speak what is the difference between the two. If we imagine that the heart has only 3 cells, just for simplicity's sake, we have only 3 cells. If we say that these 3 cells had become 10 cells, or more than 3 cells, so there is increase in number, not in size, but just in number. If the number has increased, we say this is hyperplasia. But if there was increase in size, but the number of cells was still 3, we say it is hypertrophy. So why does the heart undergo hypertrophy and not hyperplasia? It's for really important symptoms, because the heart muscle is considered to be one of these stable tissues. So what is stable tissue? Stable tissues are tissues that cannot divide, and we have 3 of them in our body. And I would like you to memorize these because they keep asking about them. The first tissue that is considered to be stable will be the CNS tissue, so neurons. The second one is musculoskeletal tissue. And you will be like, no, I exercise, and when I exercise, my muscle becomes large. Yes, but the number of cells is the same. It just increases in size. So it undergo hypertrophy, which is increase in size, not hyperplasia, which is increase in number. And the last tissue is cardiomyocyte, which is our example here. So CNS, musculoskeletal cells, well, basically muscles, and finally the heart muscle. Okay. So now we know in general, left ventricular hypertrophy, S4, all of this sounds good, but I don't get it, how they will ask a question about this. Well, basically what they will do, they will make you listen to a sound, and it will be an S4 sound. I would like you to appreciate the fact that we have here like an S1 and S2. So what is S1 and S2? The S's, these sounds are created by the closure of valves of the heart. So the S1 is actually created by closure of the mitral valve and the tricuspid valve, which we also call the AV valve, the atrioventricular valves. And the S2 is created by the closure of the semilunar valves, which are the aortic and the pulmonic. So between S1 and S2, we have the period of systole. Between S2 until S1, since the cardiac cycle is a cycle, it goes back, we have the diastole. So the S4 happens immediately before the S1. So this is the S4. While the S3 happens immediately after the S2. So, okay, a lot of students find it really difficult to detect an S3 or S4 when they listen to it. So to make it simple for you guys, I will make the following sound. This is S1, S2, S1, S2. Now I will make an S3. Maybe you could notice that between the first sound and the second sound, there is like a little bit of a period. And then between the second sound and the third sound, it happens really quickly. It's like this. So between the S2 and the S3, there is almost no pause, which tell you that this is an S3 because it's near the S2. Okay, what about S4? So it also makes sense. It's more close to the S1, not the S2. And if you still don't get it, guys, don't worry about it at all. You will get it in the future. It's just a matter of time. Okay. So moving on, we have to go back to our cellular adaptation. So if the stress is excessive or persistent, adaptation can progress to cellular injury, which means, okay, our heart enlarges, so what's the big deal? Well, he will keep enlarging. Okay, let him enlarge. Well, he enlarged to a point that you will not have enough oxygenation to your myocardium, the muscles of your heart. If this happens, you will have decreased contractility of your heart, because at some moment it will be like, enough, I cannot handle this without food. I need to get some nutrition from the coronary arteries, which originate just above the aortic valve. They will be like, okay, can you supply me with more oxygen? I cannot, because the muscle is too big. So you get in a situation called heart failure. Heart failure is super important concept for the USMLEs, and yeah, you need to keep mind about that. Okay, so why it happens, this heart failure? There will be injury to the myofibrils, because we said there will be a decrease in the oxygenation of the tissue, and that leads to heart failure. So I just explained about hypertrophy, and I told you it's increase in size, not number, correct? And an example is cardiac hypertrophy. So the question they always love to ask, you know that the answer is hypertrophy, but they will ask you how it happens. So if we imagine this is a cardiomyocyte, we know that inside of the cardiomyocyte we have something called the cytoskeleton. The cytoskeleton, like our body has a skeleton, a cell has to have a skeleton as well, which helps to keep all of its organelles in their place, the shape of the cell it keeps, it protects the cell from a trauma. It's like our skeleton, our actual skeleton. And in case of hypertrophy, you can imagine, you will need to make that cytoskeleton bigger. So there will be a build of structural proteins. Also, you need more organelles. So more structural proteins, more organelles, that's how hypertrophy occurs. So if you get a question, how hypertrophy occurred in case of an S4, you will say that it's due to an increased structural protein and organelles. Okay. The next one is hyperplasia, which we said it's an increase in number of the cells. And we said an example of it was the endometrial hyperplasia. And I showed you how it goes. And it can become dysplasia and cancer. And this is super dangerous. So if we have a lady, we said about the lady that has estrogen affecting her endometrium, leading to hyperplasia. Let's imagine that that estrogen level is persistent. It keeps coming and coming and coming and coming. Yes, there will be hyperplasia initially inside of the uterus. The tissue will enlarge and enlarge and enlarge. But imagine, if you keep doing something for a really long time, there is more chance that you will make a mistake. For example, if you start counting, I don't know, for example, let's say you count money, and when you are counting money, if you count 100 notes, there is like 1% chance you will make a mistake. But what if you do it 1 million times? There is more chance you are going to make a mistake. The same idea with the endometrium. When the hyperplasia occurs, you are doing this division much more often. So there is higher chance you are going to make a mistake. And a mistake in medicine is called cancer. So that's why cancer happened. Because during this proliferation, probably there was a mistake, and that led to cancer. I hope it makes sense. Okay, so that basically it could lead to dysplasia and cancer. And here we have a cool example called benign prosthetic hyperplasia. Guys, this is an exception. So since this is an exception, you have to know it, because if something is not typical, they love to ask about it. So in benign prosthetic hyperplasia, the patient will have enlargement of his prostate just because of the fact that his prostate increases in the cell number, not size, but number. But it's benign. What does that mean? It doesn't matter how much the prostate grows, it will never become cancer. By the way, just a quick physical examination finding, and I will be telling you guys always about these to help you in your clinic. When you do the digital rectal exam and you want to check if the prostate is normal or not, you put one finger inside of the rectum, you check, and if you feel like any nodules inside, this is cancer. But if it's smooth, this is normal. So you are like, okay, but I never felt a prostate before. How can I know if this is normal or abnormal, or what does a prostate feels like? Well, be ready. Take your finger right now, palpate your anterior-most portion of your nose. You can feel that cartilage in there, and that feels exactly like a prostate. And that way you can be able to know like how does a prostate feel like without having to feel a real prostate. So, okay, so the next one Yeah, so the hyperplasia, we said it's increase in number. Please keep in mind, in hypertrophy, we said there is increase in the proteins and increase in organelles. In hyperplasia, on the other hand, is the stem cells over proliferating. Please make these notes. I hope you have a paper and a pen. You have to know where the stem cells are located for each tissue. If they ask you where's the stem cells of the intestine located, you will tell them it's located inside of the crypts. If they ask you where is the stem cells of the skin are located, you will say it's located in the striatum basale. If they ask you where is the stem cells of the lung located, you will say they are the alveolocytes type 2. So you need to be comfortable with these concepts because they are super important and they do ask a lot of questions about it. Okay, so yeah, so it's a controlled proliferation of the stem cells creating us more cells. So the next concept will be atrophy. Atrophy is decrease in the mass size. Let's imagine the following case. You had someone who was in a coma for years and he was laying on bed for years not moving. Today he feels better. He finally was able to get out of bed and practice his normal life. But what happened? You look at his lower extremity and all of his leg muscles has become atrophied significantly. So what a process has occurred? Why he has decreased in size of his legs? Because he undergone the process of atrophy. Atrophy is super important to know, not only by muscles, because there is other tissue that also can atrophy. Atrophy sometimes can be a good thing. Inside of our mother womb, like inside of our mother uterus, when we were children, between our fingers, there used to be, like if these are our fingers, between the fingers there used to be like membranes. And these membranes have disappeared after we have been born. And why they have disappeared? Because of the process called apoptosis, basically, which is play a role in atrophy itself. So there will be decrease in the tissue mass due to the decrease in size. And that decrease in size will happen due to something written in a weird way in first aid, but it's super easy. I will be explaining to you. Don't worry. So let's read how it's explaining in first aid. Increased cytoskeleton degradation via the ubiquitin proteasome pathway and autophagy. Decreased protein synthesis. When you first read it, it does not make sense. But let's go back to our beautiful picture here. Remember the cytoskeleton? So the cytoskeleton, actually what happens here? We have something called the ubiquitin proteasome pathway. So the ubiquitin is just a tagger. It's just like touch something and be like, I just tagged you. So ubiquitin, it puts a little bit of ubiquitin here, ubiquitin there, ubiquitin here, some ubiquitin here, some ubiquitin there. And the proteasome be like, okay, does it destroy anything, the ubiquitin? Not really, it's just a tagger, it just attaches itself there. The proteasome, on the other hand, it's just like it's like a strong man with guns. He hydrolyzes everything that he touch. So what he hydrolyzes? Only ubiquitin. So when the proteasome comes, here is the proteasome. So the proteasome comes and he's like, oh, what I have to attack? The ubiquitin. Okay, so let me attack this. I will remove this section. And I will come here, remove this section as well. And I will remove this. And you can imagine the cytoskeleton is becoming shorter. So the cell will become smaller. And that's the process of atrophy. Okay, does anything else happen? Yes. Remember we had an organelles inside? One of these many organelles is called the lysosome. Lysosomes are basically cells that have hydrolytic enzymes. What does a hydrolytic enzymes mean? It's an enzyme that destroys. So these hydrolytic enzymes start to do what? They explode. And when they explode, they release a lot of lysozyme. And hydrolytic enzymes, which will destroy everything and basically destroy the cells. We call that process autophagy. Phagy in Latin means eating or swallowing. So autophagy is the cell eating itself. I hope it makes sense. So let's go back to first aid and now read the same sentence again and see if it makes sense. Increased cytoskeleton degradation via the ubiquitin proteasome pathway and autophagy. We spoke about the ubiquitin proteasome pathway, the ubiquitin tags, the proteasome degradates, and the autophagy, we spoke also about that concept. So I hope it all makes sense. There will be decrease in the protein synthesis as well. Okay, why there will be a decrease in the protein synthesis in case of atrophy? Well, you just destroyed half of the organelles. So decrease in the amount of the organelles, one of them is the ribosomes, which actually make you proteins, will lead to basically decrease in protein synthesis. Okay, the numbers of the cells will be decreased by the process of apoptosis. We'll be speaking deeply about the process of apoptosis because it's really high yield. Apoptosis is a programmed cell death. When the cell decides to die, it just kills itself. And it does that by really interesting fashion that we'll be explaining, I think, in the next class. So the causes include what leads to atrophy. The first one, disuse. Remember the coma patient we just spoke about? Like he was not using his muscles for a really long time, so they become atrophied. Maybe a bodybuilder, if he does not use his muscles for a really long time, they become smaller, that the process of atrophy has occurred. Arnold, like these big bodybuilders back in the time, now they become much smaller. Why? Their muscles have undergone the process of atrophy. The other way, I will be explaining every single one, denervation. So what happens? Guys, just imagine that we have a muscle here. It's in red. So this is muscle, and we have in yellow, we have the innervation to it. So this muscle has been innervated. Let's just, for the sake of simplicity, imagine that this is the triceps muscle, like in the back of your arm, triceps. And this nerve is, what nerve supplies the triceps? It will be the radial nerve. So the radial nerve supplies your triceps. Let's imagine somebody got an accident and this was cut. So you cut the radial nerve. So the radial nerve will not be able to contract the muscle. So disuse, I hear. So yeah, there will be disuse. You are not using your muscle a lot. So that's one cause of atrophy. Also, the innervation lead to secretion of some neurotransmitter that keep the muscles in a normal nutrient status and tell her to eat, basically. I will be explaining these more deeply in neurology, but basically with no innervation, the muscle will be starving and the muscle will become smaller, and it will go also the process of atrophy. By the way, guys, sometimes I know that I speak quick and you cannot keep up with me. It's okay. This lecture is recorded and all of you guys will get a copy. The ones who are attending now. If someone leaves, I'm sorry, I cannot give a copy, but the ones who are here will all get a copy. Okay. Loss of the blood supply. So if you lose the blood supply to this muscle, we are still speaking about the same muscles. If you don't have a blood supply in it, it will starve. No food for it. So simply it will become smaller. It will have to adapt for this poor blood supply. And if we speak about the next one, loss of hormonal stimulation. I would like to speak about this one and tell you about the example of the endometrial hyperplasia. So this is the uterus again. It looks bad, I know. And the endometrium, we said it proliferate in case of what? In case of exposure to estrogen. Let's imagine a lady that she is really old, she's in her 70s, she's postmenopausal. So a lady who's postmenopausal have pretty low estrogen because her ovaries are not working anymore. Remember that the ovaries here are the one making the estrogen. So no estrogen, there will be no hyperplasia of the endometrium. So that will lead to endometrial atrophy. If the lady will have endometrial atrophy, it becomes something like this. So you have seen how decrease in the hormonal stimulation led to an atrophy. So yeah, it makes sense. So the next one will be poor nutrition is self-explanatory. Okay, so the next concept is pretty important. It's called metaplasia. It's reprogramming of the stem cell. Stem cells, we just heard about that, but that was in a different concept. It was the hyperplasia concept. Now we are not speaking about hyperplasia, we are speaking about metaplasia. In hyperplasia, it was controlled proliferation. Now it's uncontrolled. So there will be like a reprogramming of the stem cells. So normally we know that the stem cells, for example, in our esophagus, in our lower esophagus, if this is an esophagus, okay, the lower portion of it, the epithelium type is stratified squamous epithelium. And I hope you guys know why it's stratified squamous epithelium, because it has like 3 layers. Sorry, not 3, many layers. And food that we eat can be irritant. So if you eat something harsh and it removes 1 layer, you still have too many to go. So you will be in a good shape, you know? Okay, so if that stratified squamous epithelium changes and become from this, and it changes it due to a persistent acid reflux. So you have GERD, persistent acid reflux, to this guy. He has to change its shape so it can deal with the acid. So it changes from a stratified squamous epithelium into a columnar epithelium plus goblet cells. If you remember, this was the exact type of epithelium located in our intestine. Why there is an intestinal epithelium inside of our esophagus? This is abnormal. Well, it has to be because he has to take care of, defend the esophagus against this acid. If he does not do so, the esophagus will simply burst. And if it bursts, it will be really bad. It will lead to something called Borja phenomena that we'll speak about in the future. So, okay, moving back. So reprogramming of the stem cells, we replace of one type of cell by the another to adapt to the new stress, the acid in our example. It's usually due to exposure to an irritant such as gastric acid in case of Barrett esophagus. So the example I just give you, this one, it's an example of metaplasia, which is exactly the Barrett esophagus. Is it cancer? Not. It's not cancer yet. So is it reversible? Yes, you have to know that everything I'm going to tell you today is reversible except 2 things. Wait for them. So, okay, also that was the Barrett esophagus due to the gastric acid persistent stressor. And now let's speak about our smoker friends. So, if someone consistently smokes, okay, like he smokes cigarettes, and these cigarettes keep going inside of your respiratory tract. I hope you know the type of epithelium inside of your respiratory tract. It has 2 names. The first one, they say respiratory epithelium to make it simple. Why they say that? Not to say the longer word, which is pseudostratified columnar epithelium with goblet cells. That's inside of your lung. So pseudostratified columnar epithelium. People hate that word. So that will be changed from columnar epithelium to a stratified squamous in the respiratory tract. Why this happened? Well, the stratified squamous epithelium can deal much better with the smoke than the columnar epithelium. But this is dangerous. Why? Because if this stress on the cells keep for a long period of time, cellular adaptation will fail, and you will have an irreversible type of injury. So it might progress to dysplasia, and that dysplasia, which is like basically, what does dysplasia mean? We'll speak about it more deeply. I just want you to be comfortable with the way that it means that the structure of the cell has changed. So if the structure of the cell change, after sometimes we will have malignant transformation with persistent insult. So if the cell will be consistently undergoing stress, and eventually it will get dysplasia, and that dysplasia can become neoplasia, which is cancer. So the Barrett esophagus can become esophageal adenocarcinoma. By the way, really quick, just a fun fact: the lower 1/3 of the esophagus is subdivided into 3/3. The lower 2/3 of the esophagus, so this one and this one, this and this, are both susceptible to adenocarcinoma, while the upper 1/3 is susceptible for squamous cell carcinoma. You're like, why? Because they have different etiologies. So the lower one, we said it was about like the acid reflux, while the upper one, it's mostly due to smoking, actually. Both of them are associated with obesity and a disease called achalasia that we'll speak about in the future. So, next we have metaplasia of connective tissue can occur in some situations. So, as you noticed, guys, most of the stuff I spoke about, I was only speaking about epithelial cells, maybe some myocytes here and there. But in case of dysplasia, we mostly say epithelial cells, nothing else. But the process of metaplasia can occur not only in epithelial cells, but also in the other type of cells, like connective tissue. So we have a process called Meiositis Pacificans. What does that mean? So Meiositis Pacificans mean the following. Inside of your muscles, you take a look at this picture and you can appreciate that there is a weird mass here. So what is the story? They will tell you. Someone got a trauma. He was traumatized, like he got hit. And after that, he started feeling a mass in his arm, like this one. So they tell you what is the process that led to creation of this. So after the trauma, the muscle here start changing. They are like, oh, I got traumatized. I better calcify and change from being a myocyte into becoming an osteocyte. So you have a making of bone from muscles. We call that Meiositis Pacificans. To differentiate it from bone cancer, because it kind of look the same, when you see it, do this. Like on the exam, enlarge the picture. You can do that in the exam, it's possible. Then make a line. Does it attach to the bone? The answer is not. There is like a little space. That means it's not bone cancer. This is Meiositis Pacificans, which is an example of metaplasia. Okay, good. So moving on, we have, they write, Meiositis Pacificans is an example of metaplasia of the connective tissue, the formation of a bone within a muscle after a trauma. I hope it makes sense. So the next process will be dysplasia. This is the last process I'm going to speak about in pathology. The dysplasia process is like a disordered pre-cancerous epithelial cell growth. What does that mean? So look, guys, the shape of the cell could be disfigured, but the structure of the cell, it used to be like, let's say, columnar. It will be like columnar epithelium or like one shape of epithelium. Now it becomes something like this, totally disoriented. So they write disordered pre-cancerous, so it's not cancer yet, epithelial. Please keep in mind, dysplasia can only occur in the epithelial, not in any other type of tissue. But it's not considered a true adaptive response because it's a pre-cancerous response. So it's characterized by loss of uniformity of the cell size and shape, pleomorphism. What does that mean? Take a look here, guys. Normally, we have the nuclei inside of the cells on the same level. But if you take a look at this one nuclei is up, middle, down, to the side. So there is loss of polarity of the cell. Polarity of the cell means where does the nucleus located. So there will be change in the cell structure with loss of the polarity of the cell. That's what they write us. So change in the uniformity and the shape of the cells. Look, all of them are misshaped. So that's decrease in the size and the shape. We call that pleomorphism. Pleo means different. Morphism means shape. So there will be different shape. And loss of tissue orientation. I told you that orientation means where the nuclei are located. So it is like all over the place. They are not on the same level. If they are on the same level, we say it is the tissue is well oriented. If they are not on the same level, we say that the tissue is poorly oriented. The last thing you have to appreciate that they also have an increase in the nuclear cytoplasmatic ratio and the chromatin. What does that mean? If you have a cell that undergone the process of becoming cancerous, this is a cell. Let's say this is the normal nucleus. This is the normal size. And now it becomes cancerous. So the ratio, let's say that the ratio of the nucleus to the cytoplasm, which is around the nucleus, was used to be like 1:4. Now it will be something like this. Look how big is this nucleus. Okay, so now it becomes a 3:4. So we call that increase in the nuclear cytoplasmatic ratio. Some students can still find this difficult, so I would like to make it a little bit easier for you. So let's just Google a random cancer, cervical cancer histology, for example. Let's just take a look at it. take a look, guys. There is a lot. Oh yeah, here it is. So I hope you can appreciate the fact that there is a lot of like, oh yeah, here it is. This is even a better one. So I hope you can appreciate the fact that here the nuclei are much bigger, so it's much more darker. So this is totally cancer. Could be dysplasia, all of that, but this is cancer. Look, it's even penetrating the basement membrane. Speaking of the devil, the basement membrane is super important, and just one moment and we'll be speaking about it. Here it is. It's the blue structure here. So, increase in the nuclear cytoplasmatic ratio and the clumped chromatin. Chromatin basically is the substance inside of the nucleus. Mild and moderate dysplasia do not involve the entire thickness of the epithelium. So, let me explain what they are saying. They are saying that if you have your basement membrane in blue, you have, let's imagine, you have multiple layers of epithelial cells, like in the cervix. Let me make it in green. So this is the first layer. The second layer, I will make it in blue again. And the third layer will be in red. If you have so 1, 2, 3, and this is the basement membrane under everything. If you have affection of the first layer only, like having this dysplasia of it, we say it's mild. The one in the middle, we say it's moderate. The one in the the lower one, the third one, we say it's severe. Okay, so 1 and 2 are reversible, 3 is irreversible. And if it penetrates the basement membrane, this is actual cancer. Okay, so this is dysplasia, mild dysplasia, moderate dysplasia, severe dysplasia, reversible, reversible, irreversible, and if it penetrates, it becomes irreversible. By the way, if you have affection of the whole thing, but it does not penetrate the basement membrane, we call it carcinoma in situ. Again, carcinoma in situ, it's when all of the, it's like when you have disoriented and the cancerous cells all over the place, but they do not penetrate the basement membrane. If carcinoma in situ, which does not penetrate the basement membrane, penetrate the basement membrane, it becomes actual carcinoma. Okay, good. I hope that made sense. So the next thing we are going to speak about is the follow. So we have normal cells that change in cell size and structure. It's here, we'll speak about it in a moment. I'm sorry, we need to finish this first. So mild and moderate dysplasia do not involve the entire thickness of the epithelium. We said about that, it's only the first 1 and 2 layers. They may regress with alleviation of the initiating cause. So if you remove the initiating cause, the thing that is leading to the stress, it will become better, basically. Severe dysplasia, on the other hand, often becomes irreversible and it progresses to carcinoma in situ, which we said what carcinoma in situ mean, we said what severe dysplasia mean. They usually preceded by persistent metaplasia or pathological hyperplasia. So to get this, before it, you have to get metaplasia or hyperplasia. What does that mean? So if someone has metaplasia or hyperplasia, it can become cancer. You have to know this. So let's take a look here. If you have normal cell and it increases in number, if it's only in number, that's hyperplasia. If it's in size, it's hypertrophy. If it decreases in size, it's atrophy. If the atrophy is not being like, if someone like was laying in a bed in vegetative state and a coma for 20 years, then he wakes up. Will his atrophied muscle gain back their function? Unlikely. Why? Because if the muscle stays there for a really long period of time, it can undergo the process of apoptosis or necrosis, which means it's an irreversible injury. Death is irreversible. So normal cell, it can get like this severe stress or injury, and that can also become irreversible. Okay. So the next one will be as follow. It will be as follow. If you have the normal cells and that normal cells changes in a cell type, so we said about the example of the Barrett esophagus, for example, we had the stratified stratified epithelium that has become stratified squamous epithelium that had become a columnar epithelium. That was an example of change in the cell type. That's metaplasia. While when we spoke about the cervix, we had the normal cells that have changed in shape and changed the structure, increased the nuclear cytoplasmatic ratio, changed in the orientation, which is where is the nuclei are located. Also pleomorphism. So this is dysplasia. Okay, both metaplasia and dysplasia, if they stay for a really long time, I mean the stress, they will become neoplasia. Neoplasia is irreversible. This is basically cancer. Okay, change in cell type and structure. It's generally irreversible, and that's basically neoplasia. So that was everything about cellular adaptation. The next topic will be cellular injury. I will not be explaining that today. That will be for our next session. So we finished two parts of our today lecture. The first one was explaining the course. The next one was explaining a topic from pathology, which is like basic science type of thing. The next chapter will be speaking about the topic from the clinical topics, which is CVS. You might think that that took a lot of time. It's only one page and it took us like 45 minutes to finish. But I can tell you the following. By the time it becomes easier and it becomes faster, and we can be able to finish up to 5 pages per day, but that will take some time. For now, you have, if anybody has a question, please ask, and after that we will have a little bit of a break and we'll come back explaining the clinical subject. Anyone has any question? Okay, guys. So I see no questions, so let's take 10 minutes break and we'll see you exactly at 5. Okay guys, so the next session of our class today, I hope everybody is here. Can you hear me? Just one person tell me that you can hear me, please.
Yes.
Excellent, thank you. So let's see, here we go. We will continue now speaking about CVS, and it will be as follows. So embryology tends to be one of the most difficult topics for the student to understand, especially in the cardiovascular system. It's not easy. I cannot tell you it's easy. It requires some memorization, but it has so much need for understanding actually. And today we could actually I was thinking, should I explain for you more about the physiology or the embryology, because they are equally difficult. But I decided to explain for you about the embryology since it goes with the book. And I want you to be comfortable with the first aid book and to be able to basically just recall where everything is located when you deal with your patient, when you have like your exam, real life interaction, and just like have it in the back of your brain always. So heart morphogenesis, the making of the heart. So how many chambers does the heart have? 4. So when does the heart start beating? At 4 weeks. When the heart begins basically this looping process that we'll speak about in a moment. 4 weeks. So let's speak about where the heart comes from, everything about the heart. So basically you have to know that it is our first functional organ of our body when we were fetuses, because it has to pump the blood inside of our body. And it starts working as early as 4 weeks in gestation. So one of the initial processes that occurs is something called cardiac looping. For a lot of students, this might be confusing, especially when you look at a graph like this. It's just difficult to comprehend. To make it simple for you, I will explain it. I will make you watch a small video, which is like 30 seconds, and then I will explain it again. And it will make sense. So, first of all, you have something called the primary heart tube. See this structure? It's called the primary heart tube. The primary heart tube has various sections, and each one of them give origin for something. So It has this portion called the cardinal veins, which are super important of making your superior and inferior vena cava. It has the sinus horns, which are super important for making your atria. And this guy, primary ventricle, which help you make your ventricle. And this guy, bulbus cordis, which also participate in the making of the ventricle. And lastly, we have the first aortic arch. Okay, and you can see on 24 days, we have the formation of the truncus arteriosus, which will make you both your pulmonary trunk and your initial ascending aorta. So, a logical question. This atrium is located down, and the ventricle is located up, the primary one. How come? It does not make sense. We know that the atria are located above the ventricle. Well, this is the process of cardiac looping. Basically, this guy moved like this up. For a lot of students, this might be like a little bit difficult to comprehend. So there is this video that I love showing to everybody that I teach in this topic, basically. And it's just like 7 seconds, and you will know it. So, let's take a look. We have the primary cardiac tube. You can see it, I hope. And here, so primary cardiac tube, it looks like this. Then look what happened. Yes, you can see here is the atria, and they are going up. The ventricles going down. So that's looping. Okay, you saw how it happened. So again, atria goes up, ventricle goes down. And that's the process of cardiac looping. Okay, why is that important? Because it gives you the orientation that your heart is pointed to the left side. If this process does not occur, your heart will be pointing to the right side. Is this possible? Of course. That's why they explain you this whole process to know the pathology. So there is a pathology called Cartagena syndrome. Cartagena syndrome is basically also called the primary ciliary dyskinesia. It's a defect in the dyning arm. What is dyning arm? Dyning arm is a protein, and it is basically this one protein that works as an AT base. It's an enzyme actually, and it's one of these motor proteins. So there are some proteins, we call them like motor dyning. Oh yeah, so dynein protein is one of these motor proteins that help move structure from point A to point B. So you can see them here. They actually walk. And these proteins help you move the chambers of your heart to the correct place. In the future, I will be explaining for you how come we get the genetic material and how does our body knows that your hand should be located there and your leg should be located there. That's for a different topic, but it's also interesting. So, moving on. Defect in the left to right dyning movement, that will lead to what? That will lead to your heart being located on the right. We call that dextrocardia. So dextrocardia is a part of constellation of symptoms which are found in some pathology called situs inversus. Situs inversus is a pathology in which all of your organs will be flipped to the other side. Take a look here. Your heart is pointing to the right in this pathology. Liver in the opposite side, stomach on the opposite side. This is abnormal. They like to show you an X-ray picture like this, or sometimes even a CT scan. They now know that all of the student gets the heart one, so it's easy for them. So now they started showing this one. This is a CT scan of the abdomen. To be comfortable of looking at the CT scan of the abdomen, you need to understand a couple of things. The first thing you need to understand that when you look at a patient, he's like this. So this is the patient, he's laying down, okay? This is his head, this is his arm, and you are standing near his legs, and this is you. You are standing like near his legs and looking at him. So this will be the right side of the patient. This will be the left side of the patient. So his liver is located on his left side, which is abnormal, and his spleen on the right side. So this is an example of situs inversus, which is due to dyning arm dysfunction. So what do you expect where his heart will be located? Well, it's in the mediastinum, shifted to the right, not to the left. Please be careful about the question, and the question will be telling you that the maximal impulse, which is the point where you feel the heart beating the best, is located at the fifth intercostal space on the right. Normally, it will be in the fifth intercostal space on the left. But if they say on the right, you need to think about dextrocardia. Dextra means right. Cardia means heart. So the dining arm dysfunction leads to dextrocardia. We heard the word dining arm before. It was in microbiology. Maybe you remember that herpes simplex virus helped move from the trigeminal ganglia back to the face using the dining arm, retrogradely, which means backward. Okay. Also keep in mind that patients who have dining arm dysfunction cannot have functional microtubules. If you do not have functional microtubules, who has microtubules? Correct, sperms. So spermatozoa. So spermatozoa, when you look at the structure of it, look, it has the head, it has the acrosomes, the genetic material, it has the neck has the what? It has the energy, it has the mitochondria. And the axon, this tail, its tail basically help it to what? Help it to move. And the tail is made out of microtubules that has dining arm inside of them. Look at these microtubules, okay guys? And the dining arms inside of them. So the dining arm will not be functional, there will be no movement. So you can think about it. The head is willing, but the tail is not moving. So the patient will be infertile. They will not have babies. Can we get them fertile? Yes. Then the nucleic material here, the DNA is normal. So you can take this and you can do a process called in vitro fertilization and inject it directly inside of the oocyte. So we inject the spermatozoa directly into the oocyte and then we implant that zygote. We call it a zygote when there's a sperm inside of the oocyte. And we inject it inside of a lady and we can have a baby, even in this infertile patients. Okay, so it makes sense, I hope. Okay, so you don't have to know each single structure yet, because that will be for the next topic. So for now, just know about the idea of cardiac looping, Cartagena syndrome, and the dining arm, and the heart starts developing at 4 weeks old. Okay. Now we are going to speak about the separation of the heart chambers. I hope you know we have 4 heart chambers. A frog has 3. Well, yeah, that's just a fact. But as a human, we have 4 heart chambers. Since we have 4 heart chambers, we have 2 atria and 2 ventriculi. The 2 atria and ventriculi are normally attached together, like they are just one big sac. So you need to separate them from each other to make the ventriculi and the atria. How do we do that? So that's the process of separation. So let's imagine that this is the heart. We have just one big atria. We have like 4 chambers, but embryologically we have just this thing, which is like big sac. So how we have our chambers? That's our topic for today. So first of all, we have something called septum primum. Septum primum. Primum means 1. So septum primum, I will make it always in green, and it will come from here. Okay, so this is septum primum. So septum primum starts originating and it starts becoming longer and longer and longer. And his goal is to what? Is to bind to this. What is this? This we call endocardial cushion. Endocardial cushion. Okay, it's important. You will know why in a second. Please appreciate the fact that this is a cross section of the heart. So it's like cutting the heart in the middle. Like if the heart was round like this from the side, we are just cutting it like this. And we are looking at it from the inside. So actually this is like a crescent shape. It's something like this. So anyway, if we look at this 2D structure, this septum primum goes toward the cushion. And it starts moving. And when it moves good enough, it separates from the wall. It has some portion attached to the wall still, and the other portion comes and attached here. And I hope you imagine it. It's like a 3D structure again. So there is a hole that was made here. How do we call that hole? We call it, since the septum primum we created, we call it foramen primum. Okay, So they write in first aid. Septum Primum grows towards the Endocardial Cushion, which narrows the Foramen Primum. So let's take a look. So, my apologies, I made a mistake. Okay, so again, initially when the Septum Primum grows, here we have what? The Foramen Primum. After that, the Septum Primum keeps growing until it reaches the other point, which is this one, and that leads to absence of what? What has just been lost? Foramen Primum. It has been disappeared. But we had the creation of a new foramen, this one, Foramen Secundum. Okay, so Septum Primum grows towards the Endocardial Cushion, which is this one, which narrows the Foramen Primum, and eventually you will have two of them, and eventually it will get occluded, the Foramen Primum, and it will go away. Foramen Secundum now starts appearing, which is this one. And it occurs inside of the Septum Primum, which we just explained how it occurs. And the Foramen Primum goes away. It just disappeared because after the attachment. The Septum Secundum, a new structure, totally new structure, start developing. What is really high yield for you guys to know that this Septum Secundum grows to the right, not to the left, please be careful, to the right. Of what? The Septum Primum. So this is Septum Primum, this is Septum Secundum. Okay, so the Septum Secundum develops on the right of the Septum Primum as the Foramen Secundum maintains the right to left flow. You are like, wait a second, you say that there is right to left flow? Yes, so this is right to left flow, and it's during embryology, which is actually normal. Why? Remember, your heart, if he was going to pump blood through the pulmonary trunk, it will not go to the lung. Baby lung are dysfunctional. The fetus lung are dysfunctional. They are not working yet. So all of the blood has to be shunted to the other side. So this is actually normal. Okay. So yeah, that the creation of the shunt during embryology is totally normal. The next thing is the Septum Secundum. It expands and covers most of the Foramen Secundum. Okay, so it keeps growing and it covers most of the Foramen Secundum. And when it covers the Foramen Secundum, it just have created some form of a valve. So take a look at this. So here we have the development of Septum Secundum, and then it keeps like grow. It grows some more, and look what happened here. So you have a leaflet here and you have a leaflet here. So this has made a valve basically. So we call that opening now Foramen Ovale. So that Foramen Ovale is super important. Why? Because it maintains the right to left shunt, that's one. And also after sometimes it just closes. And when it closes, you can imagine what will happen. It becomes something called fossa ovalis. Let me show you fossa ovalis. Fossa ovale, yeah. So if you take a look at the fossa ovalis, it is this thing. See? It's pretty thin. It's just like the cover that was made by occlusion of the Septum Primum and Secundum against each other. And that's really high yield to know. So let's speak about this again. So the residual foramen is Foramen Ovale. Okay, we have Foramen Ovale. It has a valve in it. And we have the remaining portion of the Septum Primum forms one-way valve. Please take a look here. The green one, the Septum Primum, is much thinner than the Septum Secundum. That makes it the mobile one. It's the one that moves. While the Septum Secundum cannot move, it's pretty thick. So it's a one-way valve from the right to the left. I hope it makes sense. Okay, so let's imagine that we have this movement from the right to the left, and all of this blood is passing from the right to the left, so it's all good. So what happens next? We get born. So after birth, what happens? This gets more interesting actually. After we get born, our lungs start functioning. So the pressure in this chamber on the right atrium drops, goes down. And if that is true, and the pressure in the left atrium goes up because the lungs are working and they are sending blood back to the left atrium. So see this guy? He will shut. It will close. It will just shut. It will close and will be shut. And these fuse to each other and they will create the fossa ovalis I just showed you. So They write, Septum Primer closes against the Septum Secundum, which seals the Foramen Ovale soon after birth, because the left atrial pressure increases and the right atrial pressure decreases. Why? Because the lung now start to receive the blood from your right ventricle, so your right atrial pressure also drops, and it starts sending back blood to your left atrium, so the pressure in it increases. So the septum secundum and septum primum fuse during the infancy and early childhood, forming the atrial septum, which contains in the middle of it the fossa ovale. So I hope this makes sense. So during embryology, we had a hole inside of our heart, and it makes sense. Now it gets important. Why? Because there is a pathology related to it. 1/4 of the population has a patent foramen ovale. It's 1/4 of the population have this hole. Is it dangerous? Yes, we have some mixing of the blood, but we are not dead. But it can lead to something lethal. I hope you know what is deep venous thrombosis. Deep venous thrombosis, which is also abbreviated as DVT, is a condition that occurs in the leg, mostly during stasis. Like if you don't move for a long period of time and you are sitting for a long period of time, the blood will be coagulated inside of your legs. So you can imagine which situation will make you sit for a long period of time. First, long international traveling. So in the USMLE question, they will tell you someone has came from another country to the US. So that will need to be sitting for like 12 hours or something. So that will lead to DVTs. Okay, so we have also hypercoagulable state in case of pancreatic cancer, in case of ladies who take anti-pregnancy pills, all of this stuff. So, okay. So I hope that made sense. So, okay, we have these clots in our legs. And normally, when they migrate from the legs, they go to where? To the lung. So if we take a look, they come from the legs. They started traveling in your circulation, in your venous circulation. So they go through the inferior vena cava, as you can see. Inferior vena cava, right atrium, right ventricle, pulmonary trunk, pulmonary embolism. Makes sense. So you're like, okay, so what is important about that? This sounds simple, like someone had a DVT and now has a BE. Yes, this is a typical USMLE question, but there is a different type of question they ask you. How can a DVT cause a stroke? It should not cause a stroke because all of the veins ends up in the lung, not in the systemic circulation, not in the arterial circulation, so it's impossible. But what happens is something called paradoxical emboli, which means the emboli comes from the DVTs, as always. It goes through your venous system, inferior vena cava, right atrium, and then it finds what? A patent foramen ovale. So it passes from your right atrium to your left atrium. Then it goes to your ventricle, then to your aorta, then to the internal carotid, then to your brain, leading to a stroke. So, if they give you a question about someone having a DVT that led him to having a stroke symptom, please auscultate his heart because he might have a patent foramen ovale. Preferably do an echo. Okay, so they write caused by failure of septum primum and septum secundum to fuse, and we said how they fuse because of the change of the pressure. And it may most are left untreated because it's not serious, but they can lead to a paradoxical emboli, which is a venous thromboemboli entering the systemic arterial circulation, which is also can be cause this paradoxical emboli by an ASD, which is atrial septal defect. So I hope these concepts make sense. They are not that difficult, but they can be tricky for students. So I always try to share videos about how this processes occurs embryologically, just for you to make sense. And by the way, all of the videos I showed you and I will show you in the future, please keep monitoring our Telegram channel because they will be there. Okay, so the ventricles. Heart morphogenesis continued. So we spoke about the atria, how they separate, all of that stuff. So in our diagram here, we already have this septum and we are done with it. So what about the ventricles? What about them? So the ventricles are a little bit easier to understand, and it goes something like this. Your interventricular system, I will show it to you. It contains two portions, an upper portion and a lower portion. So take a look here, guys. So there is, yeah, this one is good. So you can see your lower portion and your upper portion. So your lower portion is quite thick. Your upper portion is quite thin. So there is two different portions. And that is really helpful. Why? The thick and the thin. So if you are going to have a hole inside of this, will it be near the thick or near the thin? Of course, near the thin. So if we speak about this picture and we try to make like this is the muscular septum, and in yellow it will be the membranous intraventricular septum. So there is membranous intraventricular septum and there is muscular intramembranous septum. Just a moment, one person just. Okay, so going back to this topic, we have, they write, muscular interventricular septum forms, and it makes an opening called the interventricular foramen. So yeah, this area has been closed with a muscle, but we still have an opening, and that opening will lead to what? You can imagine. That opening will lead to basically passage of the blood from the right side to the left side, which makes sense. So the next thing they write, we have something called this hole that has been formed. And the next thing is aortopulmonary septums rotate and diffuse with muscular ventricular septums to form membranous intraventricular septums. It makes no sense if you read it the first time. So to make it more simple, we are going to explain it from the zero. So we have something called the aortopulmonary septum. What is this? It's just a membrane. Don't think a lot about it. It's just a simple membrane. It's just like little simple membrane in the middle. Okay? And yeah, so just imagine it as a membrane like this, and here it's connected to what? To the muscular intraventricular septum. But notice here, here normally we have the truncus arteriosus, which has your pulmonary trunk here and your aorta here. You are like, wait a second, you are wrong. The pulmonary trunk is supposed to be on the left, the aorta is supposed to be on the right. You are right, but I'm still right. So why? Because there is a process of the spiralation inside of the heart, which means, see this goes this side, and this goes this side. So this spiralation will make something like this. So if this is the intraventricular muscular portion, this is the membranous one, and it will be like this. It has been twisted, so the aorta comes here, and the pulmonary trunk comes here. But keep in mind that without the spiralation process, that would have been impossible to be. So why I'm telling you this? Because is there a disease that if you have it, this process will fail? Yes. Which disease? Transposition of the great vessels, which have the pulmonary trunk actually getting out from your left ventricle and your aorta going from your right ventricle. So now we can keep going. So they write, aortopulmonary septum rotates and diffuse with the muscular ventricular septums to form membranous intraventricular septum. So one point at a time. So it rotates and diffuses. So that makes sense. We just spoke about that. We said how it rotates around itself to put each vessel in its correct place. And we said about the fusion of it with the muscular ventricular septums. And now we have formation of something called the membranous intraventricular septums, which closes the intraventricular foramen. But guys, imagine if you don't have the spiralation process happening, what you will have? Transposition of the great vessels. If you don't have formation of the membranous intraventricular septum at all, what you will have? VSD, which is passage from the blood from the right side to the left side, and it can reverse actually. If you have yeah, so I hope it makes sense so far. And the last area here. So here we had formation of the muscular intraventricular septum. The next one was formation of the membranous intraventricular septums, and the spiralation process help us to make what? To put the aorta and the pulmonary trunk on their correct place. Okay, now we have something called the endocardial Cushing. Do you remember? I kept annoying you about them. They are this one in black in the middle. Yeah, this one. These are the endocardial Cushion. So the endocardial Cushion separates the atria from the ventriculi. And how they do that? See this endocardial Cushion? It's a 3D structure again. So just appreciate the fact that it's a cut in heart. So it's actually something like this. So it's a 3D structure, and they start forming what? Something like this. So what I'm drawing here, this is basically they are creating the separation between the atria and the ventriculi. So who does that? The Cushing, the endocardial Cushing. And by doing this process, they create what? Valves. The opening of the valves, the annulus. Okay? Annulus is an opening for a valve. So if you get a question asking you, where does the mitral valve originate from? Endocardial Cushion. Where does the tricuspid valve originate from? Endocardial Cushion. Where does the membranous portion of the intraventricular septum originate from? This has two answers. Endocardial Cushing is one. The second one is the aortopulmonary septum. Keep that in mind. Okay, so they write, growth of endocardial Cushion separates the atria from the ventricles and contribute to both atrial separation and membranous portion of the intraventricular septum. So basically, if you remember, we spoke how the septum primum in the atria attached to the endocardial Cushion. So the endocardial Cushion do participate in the separation of the atria. Also, we said how the endocardial Cushion participate in the separation of the creation of the membranous portion of the intraventricular septum. So the endocardial Cushion also help in the separation of the ventricles, and that's what first it tells us. So VSD, ventricular septal defect, is the most common congenital cardiac anomalies. Usually occurs in the membranous septum because it's much thinner. I hope you guys have your notes near you. Please write. VSD is highly associated with Down syndrome with a trisomy 21. VSD is highly associated with diabetic mother. Like mother has diabetes, child get born with VSD. Write also please, VSD is highly associated with conotruncal abnormalities, for example, DiGeorge syndrome, which is a primary immunodeficiency. Okay, so I hope you appreciate the idea of how we explain the topics. We don't only explain cardiology, that's useless. When we spoke about cardiac lupin, we explained genetics, Cartagena syndrome. We spoke about reproductive, the IVF, and how the sperm get immotile and how you get infertile. We spoke about microbiology and how the herpes goes from the trigeminal ganglia back to your skin in the reactivation process. So we will never be explaining one topic at a time. Yes, we have the schedule we spoke about, but still, each subject, when we'll be explaining it, we will be jumping all over first aids to be really comfortable with all of the concepts together. Okay, now let's speak about outflow tract formation. This is an easy one. There is something called neuronal crust cells and endocardial cells migration. So first of all, let me explain for you what are neuronal crust cells. A lot of students find it difficult to understand what is a neuronal crust cells. Actually, most students, when they hear these two words, biochemistry or neurology, they get panic attacks. Don't. It's easier than you think. So here we have the following. So I want you to imagine how we have babies. So sperm, oocyte attached together, make a zygote. The zygote keeps moving, become blastocyst, all of that stuff, don't worry about it. But in the end, they attach to the endometrium. When they attach to the endometrium, what happens? That's an important part. When they attach to the endometrium, this happens. There will be creation of a trilaminar disc, which from one side has the amniotic sac and from the other side has the yolk sac. So in the picture we have here in first aid, they don't mention the amniotic sac, they don't mention the yolk sac, you only have the trilaminar disc. So the trilaminar disc has ectoderm, ecto, which means outside, meso, which means between, and endo, which means in, like endoderm. Okay. So you have these three layers, and these three layers give origin to so many other stuff. For example, the neuroectoderm give origin for the neuronal blade. And the neuronal blade gives origin to the neuronal fold, neuronal tube. So you're like, okay, is it that easy? Not really. Actually, there is a couple of things you have to know. The first thing you have to know, what stimulates the neuronal blade to become the neuronal fold and neuronal tube? Two things. The first one is a vitamin. It's vitamin B9. And I would like you to know, and they actually ask this in the real exam, when do you start supplementing the mother with vitamin B9, which is folic acid, if she wants to get pregnant? You have to supplement this vitamin at least 2 months before the pregnancy has occurred. Why? Notice here, guys. In embryology of the CNS, it's between 18 days to 21 days, your neuronal tube has already formed. So if you start supplementing folic acid after that, it's already too late. And ladies, most of the time, don't know that they are even pregnant by 21 days. They know that they are pregnant maybe after a month or 2 months even. So yeah, you would like to have a blended pregnancy with folic acid supplementation even before getting pregnant. Okay, so let's take a look here. That was the first factor, the vitamin B9, which is folic acid. The second factor that plays an important role is something called sonic hedgehog. A lot of students be like, hedgehog, they start memorizing it. No, don't. So actually, how it was discovered will help you to memorize it. The guy who won a Nobel Prize because of this, when he discovered it, he went back home. And when he was going back home, he noticed something. He noticed that his children were playing the Sonic the Hedgehog, this game. And when he saw that, he was like amused. He was like, thought it was nice, so he named the factor Sonic Hedgehog. It also helped in the creation of the neuronal fold and the neuronal tube. So far so good, we are comfortable with this topic. Okay, also from the neuronal fold, we have a creation of something called the neuronal crust. The neuronal crust, which is the important thing, that's why I came here, give origin to so many stuff. One of them is this. So outflow tract formation. Neuronal crust and endothelial cells migration, they lead to truncal and bulbar ridges that spiral and diffuse to form the aortopulmonary septums. Remember the aortopulmonary septum? We just spoke about it up there. So the aortopulmonary septums get secreted by neuronal crust cells, and you have to know that. So neuronal crust cells give origin to aortopulmonary septums, which does the spiralation process we just spoke about, and the fuse of the endocardial cushion, making for you the outflow tract of the heart, which includes the ascending aorta and the pulmonary trunk. And we explained how both of these happen. So let's say that this process fails for some reason. The patient will have conotruncal abnormalities. So it can be like primary conotruncal abnormalities due to like genetic defect, or it can be secondary due to, for example, the patient having like one of these primary immunodeficiency, for example, DiGeorge syndrome. So conotruncal abnormalities are associated with failure of neuronal crust cells to migrate, and they can lead to the follows. Remember when we spoke about the transposition of the great vessels? It basically means that your aorta is coming out from your right ventricle, not left ventricle, and the pulmonary trunk vice versa. Also, tetralogy of Follow. I would like you to know two pathology, not one. Tetralogy of Follow and pentalogy of Follow. So tetralogy of Follow goes something like this. You have tetralogy, it's number 4. If they ask you what is the worst prognostic factor, it's what? Pulmonary stenosis. If they ask you which pathologies the patient will have, you need to know the constellation, which is pulmonary stenosis, VSD, overriding aorta, finally right ventricular hypertrophy. Okay, So the last one will be persistent truncus arteriosus. What does that mean? So maybe you remember, if we don't have normal formation of the septums that will separate the aorta from the pulmonary trunk, you will have something called truncus arteriosus, which is basically one big vessels leading to both aorta, which is this one, and pulmonary trunk. So there will be horrible mixing of the blood. The last topic we are going to explain for today will be valve development. So remember what I told you about valve development. I told you, if you get confused, don't think a lot. It comes from endocardial cushion. So the aortic and the pulmonary endocardial cushion valves come from the endocardial cushion. The same with mitral and the tricuspid. So to make it simple for you, all heart valves come from endocardial cushion. What is endocardial cushion? The thing in black we spoke about. So I like to imagine endocardial cushion as the heart of our heart. It gives origin to everything. Okay. They also give origin to the AV canals. What is AV canals? They are the ones that I spoke about here. If you can remember it, this one and this one. This is AV canals. Okay, good. So yeah, valvular anomalies may be stenotic, regurgitant, or atretic. Please remember that stenotic with an O, heart murmurs are problem with opening of the valve. Opening, stenotic, O with an O. And regurgitation is a problem in closing the valve. I'll be explaining each of these murmurs really deeply and give you the proper ways to be able, and the scheme and the algorithm, to help you get any question, and even in real life to get any murmur correctly every single time. Okay, so also the valve can be atretic, or it can be displaced like in Epstein anomalies. Remember that Epstein anomalies is associated with lithium toxicity, and they will give you the question regarding lithium toxicity in a patient who is bipolar, okay, because we give it for the treatment of bipolar. Last thing, the right ventricle will undergo a process called arterialization of the right ventricle, because look at the right atrium, it becomes so big, and the patient can have concurrent ASD. And that's it for today's session. If someone has a question, please let me know. So our classes in general are 3 to 5 classes per week. Each class will be 2 to 3 hours. We will be covering all of the material in hopefully 2.5 until 3.5 months. If you have any additional question, please write me in a private on Telegram or in Facebook, and hopefully we will see you